Welcome to the training, Adolescent Friendly Health Services. My name is Alicia Torres, and I'm with the Nevada Primary Care Association. The NVPCA Teen Pregnancy Prevention Program is funded by the Office of Adolescent Health through a Cooperative Agreement Award for capacity building to support replication of evidence-based teen pregnancy prevention programs. We want to remind you that the views and opinions expressed in this webinar are solely those of the original authors and other contributors and do not reflect the views and opinions of the U.S. Department of Health and Human Services or the Office of Adolescent Health. A few housekeeping items for those of you who are on the web today. If you are using your telephone for audio, please make sure to mute your computer to avoid feedback. Also, if you need to put us on hold, just put us on mute. Don't put us on hold or we'll hear your hold music. All participants will be placed in listen-only mode until the Q&A portion of this training. You may also use the chat box to ask questions during the presentation. If you are having technical issues, please call the Citrix Technical Assistance number at the toll-free number on your screen and reference access code 664-294-705. Today's training will offer CME credit, and that information will be provided at the end of this presentation. I'd like to thank everybody for joining us today. And the webinar, just so everyone knows online, this webinar will be recorded. And if you object, you can hang up now. Without further delay, I'd like to introduce Dr. Tanya Shafee, who will be our presenter.
Welcome. Can people hear me okay in the back? All right. And I want to thank Alicia and everybody who invited me to come speak to you today. A little bit of my background. I am a pediatrician, but I'm an adolescent medicine specialist. I am one of these weird-brained people that only like seeing people going through puberty. But actually, it's changing now. Many of you may know that adolescence is now really expanded to young adults. And we were just having a little discussion earlier about how healthcare systems have changed. And I'll talk a little bit about this in the talk. I am going to talk fast because I have a lot to go over. This particular talk is often done as a whole day workshop type thing, so I'm condensing this into Reader's Digest version. I'm known to talk fast, so if you don't hear me at the end, definitely ask questions. Adolescence does expand into young adults, so I think we need to think about that population, and there are some of the same barriers, even though the legal age of 18 is sort of when people cut off, when you can consent to things autonomously without your parents. And I know there's a really diverse audience. I mean, some of you made this maybe so 101 for you, you're like, I'm going to fall asleep. But I hope that you at least take home a few things and a few pearls. Because I can tell you right now, I am the director of our teen and young adult clinic at the county hospital in San Francisco. I also work in a family planning clinic associated with it through the University of California, San Francisco. I also deal with an area that's very troubling, and sometimes a lot of young people come through, is I'm the health examiners for the city and county of San Francisco. So I know about all the mandated reporting and all that kind of stuff that does come up in these types of sessions, in this type of patient population. So the barriers are one of the biggest things. And in this family planning clinic I work at, I think it's kind of a model clinic. And but the one sad thing about this family planning clinic that really serves low-income youth and young adult of San Francisco, actually throughout the Bay Area. There's always a battle. Even when you get rid of all the barriers, there's still battles. It can be funding, it can be all these other things. So I'm really hoping that if you have questions about this, I'm someone who's been very passionate about working with this population, really trying to do all the things to get rid of those barriers. But one of those huge barriers is us ourselves. So I'm going to talk about that. I'm going to give you, again, Reader's Digest version of how to make your systems of care adolescent friendly. And as you know, with electronic medical records and all these other things, you're constantly in this battle of trying to let the higher-ups know that this doesn't work for this population, how to keep things private and confidential. I'm going to talk about HEADS, but actually I'm going to talk about SHADES. Has anybody heard of HEADS as a psychosocial assessment? And I think actually we talk about this with adolescents, but I know I train with internal medicine and family medicine. This is something that I think every human being that's entering healthcare should have. I'm going to go through the specifics of that. SHADES is sort of a new term that's being used. If you have already heard of HEADS, then we'll go through what those letters mean. So the hardest thing about adolescence is this huge transition. The first decade of life, you're completely dependent on adults for everything, including giving health information. I'm a pediatrician, and I never forget when I went to my vet, they're like, you're sort of like a vet, aren't you? I'm like, you know, actually, if I think about it, yeah, I am. I have this parent who's kind of telling me all the information, I'm examining this little baby. But this changes, because suddenly the young person becomes the source of health information, right? And then they allegedly become an adult. When that happens, there's lots of, you know, laws around that, but when a person actually becomes an adult is very variable. So in young people, the reason why they often don't seek health care is because they think they're healthy, okay? And if you look at the health outcomes of young kids, it's really kind of infection disease, accidents and type stuff. The minute you hit adolescence, a lot of the health outcomes are behaviorally related. And that's where people like us get a little like, ooh, because you have to start talking about drugs and sex and these other things. And I think our healthcare system often keeps adolescents as little children or big adults. And we don't really know what to do with this age. But why I'm really passionate about it, and why I find a lot of rewards in this, is you can make a huge difference early on in a young person's life. Just talking to them about smoking cigarettes. Just talking to them about what their family planning plan is. Those things can make a huge difference, and that's where we come into play. And that's why I think we really need to focus our resources on preventing these things from happening in the first place. I know that I have like an obesity clinic right now, but they're in an age where it's so much easier to change their habits that aren't 25 years in the making, okay? And this is, I mean, I know our systems of care don't really focus on this population. I think that's changing. I can tell you in Northern California, Kaiser, I was a Kaiser doc for a few years. They've looked at this. They get this. It costs us a lot of money downstream. Let's invest in creating teen and young adult clinics throughout our systems, because that's where they want to go. So adolescence is a time of what? Identity. This is when you start to really form who you are. And it may not be what your parents think you are. And it's shaped by all of these things. And as you go through it, you start to see where more and more peers influence the decision-making and how they do things, and less parents. I mean, I had a young patient the other day. She was brought up as an evangelical Christian. She's now converted to Islam. And that's her, and there's a lot of anxiety around all of this. She comes in, like, first time I ever saw her was her hijab on. I'm like, who is this? You know, I hadn't seen her for about a year. And this is when this starts to happen. This is this is a whole separate talk in itself around cultural competency and cultural humility. But I think what you really have to understand is that adolescence is a culture. And I'm going to kind of go through this because I think it's important. You know this. This is when the tattoos start to come on. This is when the hair turns green. This is when they're doing everything that you weren't planning on with young people. I sometimes I have to who are you? Oh, yeah, I remember seeing you last year, you know, when you're in your little Catholic girl school outfit, and now they're like, you know, woo. And sometimes you may not understand what they're saying. I won't always speak in adolescence, but sometimes, you know, I'll go, hey, you know, it's hella good. You know, just because I've been in clinic all day. It's like, woo, I got to get back to my culture. And I think, and that's, you know, and they make a big difference the next year. You know, you never know. But I think the thing that we, as adults and sort of healthcare, we sometimes look at them as like, oh, it's a teenager. I can't stand teenagers. I get this all the time from my peer colleagues. Pediatricians are like, I'm so glad you exist. You can just take all my patients, because I just really don't. But I want you to kind of think about that, because when we look at cultural competency, and this kind of expands to everything, the reason we talk about cultural competency is it brings culture into the conversation around how to provide healthcare. We know this, because the end result of not being cultural competent is what? If you're not culturally competent and you don't provide good healthcare, what happens with healthcare? You see disparities. Okay, we know that. There's a lot of reasons we have health disparities, but we have to really look at what that's about. So kind of understanding how culture, and I'm not just talking about race, ethnicity, I'm talking about the whole thing. And again, adolescence is a culture. It's an age. It's different than being an adult and being a child. And understanding cultural concepts, being that makes you understand these differences so that you can address them when they come out. But the one thing that's not good about cultural competency is, not advancing, is the weaknesses is that sometimes if you do that, you think you understand a culture, it can lead to stereotyping. And it gives you a concrete level of knowledge. And it makes you assume that just because they're this, they're always going to do this. And that can also create some health disparities. And it really reflects on the others and not kind of how we are. And so whenever I now kind of address things where I see something coming up where communication is not happening or something, I think the more important thing is to be have cultural humility. Have people heard this before? It's not, okay, I mean, I'm good. I'm glad. I just want to make sure that we're kind of on the same page. Because I'll give you an example. I had a young woman who, trying to make a long story short, she's Guatemalan, you know, came leaving the whole, you know, violence that's going on in the United States, barely understands the healthcare system. Mother watches her menstrual cycle like a hawk, wanted to be on birth control, didn't want her mom to know at all. She was sexually active, so we went with the Paragard IUD. She really wanted that. Came, made her own appointment, got the Paragard. It was all wonderful. 9 months later, she's pregnant with the Paragard. Doesn't want to be pregnant. I'm like crying. She's crying. I'm like, this is not supposed to happen. It's really not supposed to happen. And all she kept saying to me is, I don't want to kill the baby. I'm like, okay, I got to take a step back and think about that. I had to be really I had to have cultural humility and understanding. This is her culture. Getting pregnant, there's no decision about what's going to happen. And as a 15-year-old, it's kind of a normal thing to have a child. And actually, it was a really good thing. Disclosing it to her mom finally that she was pregnant, she tried to do everything. They actually came closer together. And again, I had to understand that for myself because my own bias was like, oh, you know, you got to think about abortion, and I was just leaving it open, but it was like my own like bubbles over my head. Like, that's the moment where you stop in your tracks and go, let's look at this. This is my own biases. I have to address those own biases. So this is just sort of, I'm not sorting again, sorry. Thank you. So when we think about that with cultural humility, it gets into sort of where we are developmentally as well. And I say this because younger adolescents, I still have a bias towards. They're so concrete. And I think this is really important when you're interacting with adolescents. People put adolescents in this big box. There's this whole group of people over here. There's a huge change that's happening. And with young adults, and I have 18-year-olds who are still really early adolescents. They may be biologically mature, but they are so concrete. It's like, you know, that's why you have the question, are you sexually active? Do not use that question, because they will say no. But they're like, today I'm not. Tomorrow I might be. You really got to think about who you're talking to. And when you ask an abstract question like, well, how do you feel about your body? They're like, fine. You know, a concrete young adolescent, and I put ages up there. I have a whole talk on development. Age does not equal development. We use age as a proxy for development. And I wish we could give a developmental test to everybody. Like at 13, 14, 15, like, okay, yes, you can drive now. Okay, yes, you can drink alcohol now. Okay, yes, you can join the military. I mean, honestly, think about it. It's not. I have 24-year-olds sucking their thumb in my office. Okay. So, but what happens in that lesson? So the early adolescents, the body's changing, and what are they focused on? The pimple on their nose, they want it gone today because I'm going out this weekend. That's as far as they can think, right? You know, you can't talk to them about, you know, the meaning of life and all these other things. Their body's changing. They can now reproduce. Their brain may not be ready for that, but their body is there to reproduce. We know that. They're going through puberty. They're having all these changes. You know, guys are like, it's not right down there, and girls are like, my boobs are not right up here. You know, it's just really, really, really the understanding of their body. The brain's not there yet. Middle adolescence, I think of as exploratory time. And this is actually really healthy. How do young people learn these really complex things that are going on in their lives, right? How do you learn trust? That's an abstract concept. How do you learn rejection? How do you learn intimacy? You can't really do that, but you have to kind of get into a relationship. And I'm not just talking like, you know, sexual ones. I'm just talking with their friends and everything to understand what that is. And that's a really challenging thing, and you can see that. I think some of the most amazing interactions I have with young people have really broken up with someone. We have a lot of conversations about that. Like, how did that make you feel? So they've learned for the first time, I got burned. I really like this person, and they hurt me. You know, and we don't talk about that in the healthcare world. I think it's so important. And forget, you know, I'm talking about adolescents, even in the adult world. I mean, these are things we're all struggling with as adults and kind of sharing that. But they need to have that time where you're with them and you're talking with them. to help them become independent. And more concretely, it's like they need to be their own health historians. They need to understand how to tell their own health history. They need to understand what happened in the past and what's going on now, because they are going to be independent. And sometimes if parents and us are really smothering them and not allowing for that, then they can't, they don't know how to use the system, and they're kind of stunted. So, older adolescents, we look at 18 and older, but this is when technically you are able to abstract. But it may be in one part of your life. I had this young man who was an early acceptance to MIT. I was like, wow. I couldn't even tell you the kind of engineering thing he wanted to do. I've never heard of it before. He's quite smart. I asked him, so are you in a relationship? No. Have you ever got a crush? No. It's like, okay. It's like, I don't want to be, I don't have time for relationships. And it was interesting to me. It was sort of like, he's very, very excelling over here in an academic, cognitive world. But over here, socially, he's like, no. And I could tell it was more fear-based. But it was like, well, I was worried he might be really set up to be hurt the first time he kind of has that crush. But he was 17 and never really had a crush. And I think that's the important thing to really kind of address. Again, I have a whole talk on adolescent development. This is kind of Reader's Digest version today. So what are some of the barriers that young people have? And I wouldn't just say this for adolescents, because I think these are sometimes the same barriers for young adults. And we're learning that now. Young adults do not really like going to the adult world. They go to family planning clinics because they're kind of geared towards them, if you think about it. On college campuses, they have their kind of student health. They're really geared towards that population. I think our own healthcare system is kind of like, what do we do with these 22, 23-year-olds? But confidentiality, I can't stress enough, we have a whole few slides on that. Poor communication, assuming that, again, that they're little kids or big adults and not really understanding where they are developmentally. This cultural humility part, kind of being insensitive. Oh, it's a teenager. They miss their appointment. They're late again. They don't follow up, all these kind of things. That kind of attitude about it. Us not knowing about it. I can tell you in the medical profession, pediatrics is the only one that trains anything at all in this area. I'm working with internal medicine and family medicine residents because they don't get specific training in this. So don't assume that we're all getting this training. And it is a huge need now that we have more young people in systems of care. Money, insurance, transportation. Don't assume just because the parents have been, and this is a new thing that we're learning, the parents have been enrolling young people in their health insurance, right? They age out of it. Then what happens? They don't even know. I'm supposed to enroll. I had a young woman. She came in for the first time ever, and she came in after she had an appendicitis a month ago. I said, is everything okay? She's like, no. I go, what happened? She goes, that appendicitis bill was $57,000 for that hospitalization. She didn't know she needed to enroll in healthcare in order to have emergency care, da-da-da. And that's the thing. I use that story because it's like, you need to get enrolled. Location and times of day. This is where, like, the clinic manager is like, we're not staying up past 5. This is where if you really want to learn something, look at what your patient population wants. We might need evening clinics. I work evenings 3 days a week. I actually really like it because I have an asthma brain. I don't work very well in the morning. So it works great for me. but it's thinking about it. I'm having Saturday clinics. And knowing how young people get to your clinic. Because not all drive cars, and they may have their parents that they have to use. So I think we talked about this, and this is a great thing with kind of the changes in healthcare, because the previously most uninsured population was adolescents. Now it's young adults. We kind of know that again. They're insured under their health plans with their parents, and I work, with all public state funding. And then, they'd age out, and that was it. They could go to family planning places to get their care, but now they don't. So, but what we know is young people who are insured go to offices more than those that don't. So those are the people that we're missing. That's not. All right. So this is to help us kind of think about this. So you're got a new physician in a pediatric office, and they see a small population of adolescents, but we should expand this population. Does that sound familiar? So what I just like a couple little insights. What do you think you would like to do to kind of create team services? 1 or 2 things. Would you have a diaper changing room in all of the exam rooms? Actually, sometimes screaming babies can be a great form of contraceptive prevention. They do immunizations in my clinic, and you hear this, when they're getting their shots in the exam room next to you. Like, okay, think about that. Anything? Yes.
Text or social media confirmation of.
Yeah, I think unfortunately the patients are ahead of the healthcare providers in this. And I've been emailing the patient right now about coming in to see me tomorrow. Because calling, you don't call, you text. You use your phone to text. You just send the email. You don't talk to people, right? I've had patients like with their friend in the other exam texting back and forth. Like, God forbid I should not say, my doctor's giving me this one. I'm getting this IUD, or I'm doing whatever. It's kind of funny. So this is just, and you guys can have access to these slides. It's sort of the laundry list. There actually is sort of accreditation on how to make some place adolescent friendly. It takes many disciplines. It shouldn't just be in one department. The ones that really work well. And the great thing about this is we all learn from each other's disciplines. I work a lot with psych, family medicine, OBGYN. Those are like some key ones. And I learned a lot. I was never trained in how to do IUDs or implants. It was through working with my OBGYN colleagues. They didn't know how to deal with confidentiality and all these other things in development, so they talked to me about that stuff. It's really, really, really fun because you kind of get outside your little silo of your own discipline. If you can get from the barrier, some other things that need to be addressed. Just little things like putting teen stuff on the walls, you know, and in the bathroom is something. Having pamphlets out. I can tell you, sometimes I do pamphlets out, you know, like on contraceptive methods and kind of, sometimes the parents are taking that stuff too. You know, they come in because, you know, they don't want to get pregnant. But this is just something to think about. And then really looking at how to transition into the adult healthcare system. And that's why a lot of places have expanded young adults, because a lot of young adults don't feel comfortable in the adult system of care. If you can have health education, have peer education, using outreach, working with your school districts and your school-based clinics if you have them, or knowing what those systems are and linking. A lot of places now are working with, schools can't necessarily have school-based clinics. You can go, you know what, we have a system where you can come to our clinic during school hours, we'll sign a release, da-da-da-da. That's where you have to really look at school districts to set that up. Because I think a lot of school districts, like, we would love to have someone. And having someone go to those schools and teach just basic 101 health ed can be really, really helpful. And it sets up a great kind of network. So these are just things to consider. I'm not going to go through all of these in the interest of time. But some important ones is the confidentiality part. Okay, and I can't stress that enough. And there's a lot of research to sort of discuss this. Well, if you're setting it up, these are just kind of the basic things. You can definitely expand off of this. I know a lot of systems of care, and I know there's behavioral health people. Having integrated behavioral health is a godsend. We've been looking at, like, what are the health issues of young adults? You know, they're new to our system. They're not really getting primary care regularly. Their health issues are reproductive health and mental health. I mean, and sometimes there's a lot of overlap. And I think that's something that's really important, because I get so many patients, with young adults particularly, all kinds of somatic stuff, all kinds of stressed out things, trying to find jobs, trying to find a place to live, trying to get out of the parents' house, and they're just freaking out, you know. And then they come in because the girl hasn't had a pregnancy, you know, hasn't had a menstrual cycle, just really stressed. So I can't emphasize enough. But again, being multidisciplinary, working, because you're dealing with a lot of family planning. Thinking about that, thinking about if you yourself can't do it, who would you refer out to? Can they work with you? Can they work in your clinic? Can you work in theirs? That kind of thing. And then making sure when those referral systems that you have, that they are teen and young adult friendly. I refer to some mental health places where I'm like, I'm probably not going to refer back to them. I have one bad example of a really nice psychiatrist, but I don't think she was trained in how to keep things confidential. She actually disclosed to the mother in front of the mother that the girl was sexually active, and that backfired. You know, it's like, oops, okay. And you don't want that to happen. You don't want to make the referral and then go, sorry, I didn't know that. So the actual visit. Michelle's a 15-year-old woman who's come to your clinic with her mother complaining of an ear infection. Her mother requests to remain in the room for the exam. Has anybody ever had that experience? I know you're working with families now. It's an issue. It's a constant issue. But I think if you think a few steps back, how can we make this situation a little better? And she's coming in for an ear infection. She's not coming in for a pregnancy test. So again, this is really based on evidence. And actually, one of the women that I trained with, she's kind of done a ton of research on this, and we know this. When you discuss confidentiality up front, again, think concrete. We know that this helps establish trust, and that's the thing that's happening. It's no longer just health information from the parent. You really need to get the health information to the young person. And it's not just all this, like, sex and drug stuff. Sometimes you really need to get the unbiased opinion of the young person. I've had that often. I have a case coming up about, you know, being overweight. And you may have the parent that's nagging this kid about their weight. And they just won't talk to you about what's going on with the parent. They're like, yeah, they're drinking juice all the time. I keep telling them, I don't buy it. That's not a good interaction. You want to establish a relationship with the young person to help them, right? And that's why it's really important. And I think to kind of demonstrate that, I have a video that we're going to show about that. There's a lot of research. There's a lot of research to show that this actually is true. Yeah, it's not advanced. Sorry. There you go. We also know that when you don't establish trust, they won't come back to see you, and they may not seek health care at all. That's the other thing that's really interesting, particularly when a young person comes in for the first time for maybe family planning type stuff, or they came with their friends. You know, they have a bad experience. That's what they're going to stereotype about healthcare providers. They're going to tell my parents they're really demeaning. They're condescending. I'm not going back. I had a young person who was diagnosed with herpes in the ED, and she was so demoralized after that. She never sought care again, and she had a few flares after that and was suffering. And she said that. She finally was breaking down and crying. She felt so stigmatized by it. And it was because of that first healthcare interaction. So you have to do damage control after something like that. And then having them come back. One of my advisors, I always ask her, how do you know when you're doing good care for adolescents? They go, they'll come back to see you. That's when you know. They may not actually come back to you. They'll email you. They'll contact you. They come back. They've got that. You've gotten a little bit over that trust. They're not coming under mom or dad's, influence. They're just coming back to see you. This is also something that's developmentally, because again, you're not going with confidentiality when they're 5 and 6. And a lot of people assume when you're 24, 25. And remember, a lot of young adults are living with their parents now, so there's still kind of this stuff going on. So I think it's really important to help them and to understand, because this is why they are going to be giving you the information. You have to kind of meet them where they're at. This is confidentiality is like, kind of 101 of adolescent health. But when sometimes you get, like this particular case I presented, you might get, oh, no, I know everything about my daughter. We talk about everything, da-da-da. I'm staying in the room. She doesn't know how to talk to a doctor. This is why we do it. I think it's important to really get parents, and this is why you want to do this conversation kind of when they're 9, 10, 11. It's like, we're at a very time where we want to really get to know your son or daughter alone. It's not about trying to go behind your back. It's just having them have a relationship with us. You're still a huge part of this. And if we're ever concerned about anything, we would absolutely let you know. I think those are the things. And so with young people, you may have to go through the explicit limitations. As far as all care, we know that young people in every state in this country have the right to seek services and consent to those services by themselves. That has been grounded in the Supreme Court, actually. Every state is different on what those services are, and that's where you have to know. There's always things that are trying to change, or allegedly they're having another ballot initiative on parental notification for abortion in my state. But I think it's important to really have the parent not just be totally a parentectomy, which we talk about this time. It's kind of like the one on parentectomy, but sometimes we want to have them dangling there because they are a good influence in this young person's life. So this is why you may want to do this up front when they're 9, 10, 11. And we know this. One of the reasons we have a lot of vaccines at 11 years of age, because that's like the last time you kind of see them, right? Get them before they're off and gone. But this is where you want to have a letter. You may want to have signs. You may want to have it in your 11, 12-year-old visit. We're going to start to see your son or daughter alone. They can actually, I even tell them, I go, you know what? Some parents like this. They can come by themselves. I will get in touch with you. I know I need to have consent for vaccines and things. But I want them to take responsibility. I want them to learn how to make an appointment. I want them to learn how to go to a pharmacy and get a refill. Think about it. If they want pills, what are they going to have to do? They have to learn how to go to a pharmacy and get a prescription. This may be the first time they do that. And we assume they know how to do that, but they may not. And this is kind of getting them to kind of navigate the healthcare system and know that they can come by themselves. I can definitely take questions about explanation of benefits. I know that comes up. And if people don't know, that's when you do confidential services on parents' insurance and sending the bill home. It's a huge issue. I understand. That's why you always have these workarounds. And that's kind of because adolescent health is nothing but a bunch of workarounds. You're constantly working with EMR systems. You're constantly working with how to use your phone reminders. You're constantly working on how to get lab test results. All these things that, the adult world and the pediatric world are not totally in tune with. And that's something you always have to think about. But displaying things in the exam room, maybe a sheet of paper, however you want to do it, just having them. I'm going to give you resources of some websites. The Adolescent Health Working Group.net, ahwg.net, has a whole 101 on consent and confidentiality. They even have examples of these types of things you can post in your exam room, so that young people know what it is about confidentiality. So I'm going to move to the video. And this is kind of a demonstration of the case I just gave you. The parents didn't want to leave the room.
Caitlin is a 14-year-old girl who comes to the clinic with her mother for an annual school physical. Her mother requests to stay in the room for the entirety of the visit.
Hi, Caitlin. I'm Dr. Ornstein. How are you today?
I'm fine, thanks.
Who did you bring with you? Is this your mom?
Hi, I'm Karen Hammond.
Nice to meet you. What brings you guys in today?
She needs to get a physical before she starts school.
It's definitely that time of year. Let me just tell you how things work in our office with our adolescent patients. We're all going to first meet together. I'm going to get her health history from birth on up, see if there are any current issues that are going on. Then I'm going to ask you to step out of the room, and I'm going to talk to Caitlin alone for a little bit, and then I'm going to do her exam, and then I'll bring you back in to wrap things up at the end, okay?
If it's all right with you, doctor, I'd like to stay in the room for the whole time.
I understand. It is a bit of a change when your child starts going through adolescence. Caitlin needed you to stay in the room when she was younger. She didn't know her health history, and she probably was a little nervous to be around the doctor, but at 14, it really is developmentally appropriate for Caitlin to spend some time with the doctor alone. She does need to start taking some responsibility for her own health, and it's also our office policy that we spend some of the visit alone with the adolescent.
Listen, I'm not the enemy here. I want what's best for Caitlin. Wow, stop. I just don't get it. You don't tell me anything. You're going to tell her everything, and then she can't tell me anything.
I think I'm a parent here, and I would want my kids to come talk to me about everything that's going on in their lives, but I also do know that there are some things that kids don't feel comfortable talking about with their parents. So if my kids couldn't come to me, I certainly want to know there was another responsible adult they could talk to, like their doctor. At least that way I know they'd be getting factual information, and if they were in any kind of danger, they would get the help that they needed.
Do you know how old I am, doctor? I'm 15 years older than Caitlin. If my mother had known what I was doing when I was her age, I wouldn't have been doing it. My life would have turned out very differently. But instead, the doctor asked her to leave the room.
I hear what you're saying. I know that you love Caitlin a great deal and that you want to protect her, and it must be very difficult to see her at the age that you were when you had her. You need to know what a strong influence you are on her, on the decisions she's making, on the path she's taking, on her way to becoming an adult. You've been waiting 14 years for her to become an adult. I'm sure it's really scary right now, but this is one of those steps, and I think it's really important. Is there anything that you had concerns about or anything you wanted me to discuss with her when I spend my time alone with her?
Tell her not to have sex. If she does, to be careful. Oh.
Listen, we both want what's best for Caitlin. We want her to be safe and healthy, and during my time with her alone, that will be my ultimate goal. Okay?
Okay.
Caitlin?
Okay.
All right, why don't we get started with the history?
This is, again, a lot of these, and has anybody seen this kind of scenario before? You know, okay. There's some other layers, and again, like, we use this kind of in this whole talk, but I think the point is that you're not trying to just go against the parents. It's really trying to make that connection that you did. This is from the Physician's Reproductive Health. You can look at this video, and they're used for training with along about another 25 videos that you can look at. So I mentioned the whole thing of HES, which we're really trying to reframe to shades. And the whole purpose of this is to really kind of take away from just doing a risk assessment and really kind of focusing on strengths, because that's sort of what I don't think we do enough as healthcare providers. And it gets into kind of looking at young people as just this, you know, age of just doing everything terrible and like trying to find out what they're doing wrong. And we don't. And it's really kind of fun to really look at strengths. And it takes kind of really tweaking things to understand and get information. So this is sort of the acronym, and you don't have to necessarily remind yourself of all of this. And each category has a separate set of questions. And from a perspective of time, you know, adolescent visits take longer. That's a given. And if you're only given 10 minutes, I know. And I started working at Kaiser as the first teen person. They gave me 10-minute visits with some of my teens. Like, I was like, no, not going to happen. If you want me to be here, then give me the time with the young person, because it is more intense. But you can do a lot of upfront stuff. And as we talked about with technology, there's more and more online health happening. If you can figure out a system where you could get a questionnaire to the young person the night before their visit, have them have this. There's some systems with patient access to electronic medical records. They fill out the whole questionnaire before they come in, and then it's tailored to the answer so that they have all those questions for the provider, and you have all that information up front. You know they're having sex, you know they're smoking a little marijuana, you know they're doing okay in school, you know, this kind of thing. This is kind of the upfront thing, but it is fun to engage and kind of have these conversations. So I'm going to go through each of these categories. Strength is really taking the looking at what makes a person resilient rather than just focusing on the other things. Not every kid is doing everything bad. They have sometimes often negotiated things. You know, they may smoke marijuana, but they're not drinking and driving. What is it? So kind of looking into how do you understand that that's healthy? How have you been able to negotiate not getting in a car and drinking with someone? What are the ways that you've been able to be effective at that? What are the things you're really good at in school? What do you think you're really good at? Every kid does that. They're good at something. And give them feedback when they do. So good to see you again. I can't believe you're here today. Do you remember my name? It's like I do that all the time. Spirituality, we know it's a huge protective factor. And I'm not just talking religion. It's important. And it's also an indicator, because sometimes they may say, oh, you know, I hang out with my family, go, you know, we have a service on Sunday or whatnot. They may not be really engaged. Again, this may be kind of indicating where they are with identity. They may have issues with who their parents are and their religion and not who they are themselves. And I bring this up because I have one of my favorite questions around sex is, or getting into sexuality is, when do you think you're ready to start having sex? I love this question because it's a great developmental question. And often I'll get when I'm 18. What does that tell you about the young person? Concrete. I've gotten when I'm 35. I'm like, oh, yes, I need to go to college, I need to have a mortgage, I need to have a career, I will not have sex until I'm 35. I'm like, okay. Honest, I get these messages. Honest, anything. And, you know, I'll get when I get married. Oh, when does that mean? It's like, and then you're getting these influences. Is that what they believe, or is it their parents? You know, this kind of, they're influenced by what their culture is. But it's just something to think about, and then kind of incorporating it. So home has, this gets into sort of the context of who they are, who their caregivers are. I do, again, I'm not going to go through all of these. You know, I work with a lot of young, I would say half my patients have been in and out of foster care, so that's a big issue. That changes everything. Are you going to be here in this county this year? Are you going to be moving to another county next year? Employment, huge one. I get a lot because I'm in the state-funded insurance system. They suddenly parents lost their job in the Kaiser. There's a lot of stress going on, so now they're seeing me. Education, employment, I think this is really when you can really find the strengths part, but sometimes there can be a lot of the risk factors. So how are you in school? And it's not just like how they're doing academically, because what is school? It's learning the academic stuff and learning humanity. It's learning like all this stuff, this social stuff that's not going on at home. And this is where they're actually learning a lot about hierarchy stuff and who has authority and who they are and bullying and do they feel safe and dynamics and teachers they hate and teachers they love, and, you know, all this stuff. There's a lot going on. And that's why, and this is where they might start getting, or peers getting their goals in life, what they're good at. They might be starting to learn that I really like art. Employment's another one. That's a milestone. Another milestone for young people is to have, you know, starting with allowance and these other things, showing that they can demonstrate things. But it can be the other side. There can be some risk factors, like they're working 30 hours to support their family, and suddenly someone lost their job and now they can go to school. And I see a lot of that. Eating, big one. And I kind of throw this myself under activities. So this is, you know, a huge problem in our country. 50-year-old female comes to your office, notice she gained a bit of weight. When you ask her to stand on the scale, she begins to cry. So how are we going to address this? And I actually have this as a reason why parents step out of the room, as I alluded to earlier. Because sometimes this can be a really stigmatizing thing. It could be, and I've had young men who are really underweight, and this becomes a stigmatizing thing. So it's not just, you know, overweight younger girls. I always frame it, do you think you're healthy? Because I would say 90% of the time, young person will say no. They've already maybe been struggling with their body and stuff, but that is a way to trigger me into kind of getting into it. Starting way back, not like, are you concerned about your weight? That might be the second lens. It might be a backdoor way. We have it on a questionnaire if they're concerned about their weight, and it gets into that. But then it gets into what works and kind of the details of that and getting more of an assessment. Activities. I have, this is our people from YRBS, Youth Risk Behavior Survey. So this is some stuff that was pulled together from some of the people and it's blue is Nevada, yellow. I was looking at this, reviewing some of the information. It's great. You guys are doing great on some things, and then on other things. It's kind of interesting. And this was done from 2014. We don't have it's done every other year, and it's done on 10th and 12th graders, so it's kind of compiled kind of thing. But as you see, this is kind of an indicator of health, and these are the questions that young people are asked. So you guys are doing okay on the how much are they in front of the screen type of thing, but compared to the national average, but maybe on the not having PE classes and not being active for 5 days. And the response you always get was, how do you spend your free time? Hanging out with friends. We have to have this thought. What do you do with your friends? To kind of getting into that. And this also may be the huge social learning time. It's when they're hooking up with people. It's when they're hanging out. It's when they're doing things. It's not school hours. But it's also indicating some of the resiliency things. Like, yeah, I'm involved in some after-school things. I'm involved in and that's where I usually go off on my thing. That's when I really feel like I'm learning who they are as an individual and what they chose to do, what they want to do. They're finding they're good at sports. They're finding they're good at art. These are the really kind of learning things that they've identified for themselves. So the more the drug, sex, rock, and roll part. As you see, you're kind of up and down. Alcohol before 13 a little higher, but heavy drinking a little lower, so that's good. Ever used any substance? I can tell you California is off the charts with marijuana right now. and we even have on our form, does anybody in your house smoke? And they don't say cigarettes, and I get positive all the time because parents are smoking weed. It's one of these things. And this is kind of a national, actually marijuana smoking has almost overtaken cigarette smoking nationwide. But it's definitely more of a problem in urban areas, and who knows if they'll expand this or suburban or rural areas. Alcohol, of course, is still the #1 thing. And this is, pretty straightforward. But the one thing I want you to think about is I just saw a report about e-cigarettes. It's definitely on the rise, and it's promoted as kind of being healthier or whatever. It's a whole other topic in and of itself, but we're finding it is kind of a gateway to cigarette smoking. And it's passive smokes it helps with it, but it's not. It definitely seems to be being targeted to adolescents. And then getting into more logistical things, actually passing out and blacking out. And if you do have any of these positive responses doing craft, I know many of you have heard this, but it actually has been shown, evidence that it's applicable to adolescents and adults, not just youth and adults. But sometimes you may have to frame some of the questions a little bit better. I often drinking alone is a huge one for adolescents. I mean, for adults, it's kind of a big one, but for adolescents to be drinking alone, that's a huge red flag. And that's where you may need to get some help. My favorite topic. Here we go. So this is nationwide. Kind of these are pinker boys and oranger girls. I didn't make the colors, but it's sort of showing you. So and I could put this in any country in the world, and you might see the same graph. So this is humans. Humans start to have sex in adolescents everywhere. Actually, there's another chart that we have. Is when do people get married? In the United States, it's gotten older. It's actually like mid to late 20s. It used to be early 20s. So you have this whole decade from when a young person has sex to when they actually get married. Now, there's some population that may actually wait until they're married to have their first sexual encounter. I had a 29-year-old the other day who was about to get married and wanted a pair of arms. She knew she was going to. So this is the biology. And as you see, that actually boys usually start having sex younger than girls. This is Nevada, so the whole state. This is interesting. So you guys are better at under 13, but as you and actually as all ages and number of partners. So your risk factors are a little lower. Unfortunate thing is, even though they're having less sex, higher pregnancy rates. So just kind of a very fertile. We're talking about this earlier. Very fertile. And the good news across the country, this is of course going down. And there's a lot of layers in this, which we could talk about. But let's look at some of those. Using birth control and using LARC. This is a huge goal in the country, is long-acting reversible contraception, really promoting that. Both ACOG, American College of Obstetrics and Gynecology, and American Academy of Pediatrics are really promoting the first-line contraceptive method should be a LARC method. Kind of don't dabble with patch pill ring, just to think about. But as you can see, they're kind of on average with the rest of the U.S. Anybody know this answer to this? What is the time frame from when someone starts having sex to actually getting health care? Can anybody guess? 3 to 6 months? A year? 14 months on average. You know what it is in the Netherlands? 0. Most young people are on a birth control method 6 months before they have sex. The whole other talk that I have about the cultural differences from the other European countries in the United States. And if you're coming in for pregnancy testing, that's sort of an admission that you've had sex. The sex history is a huge area. But the one thing, and I listed all these things that you sort of want to know, but one thing we don't talk a lot about is, do they like sex? We don't talk about why people have sex. Our culture is sex is terrible, be afraid of it, you're going to die of it, it's going to give you all these sores, it's going to make you have discharges, all these things. But people do it, even knowing all that. So it's one thing, so we don't talk about why people have sex, which is so important. And this is sort of like the laundry list of how to kind of frame this. You know, don't ever assume. I've been caught in that. You know, I had a young girl who had an abortion. I'm like, so how did your boyfriend feel about birth control? She's like, I don't have a boyfriend. I have a girlfriend. So don't assume these things. It can really put you into these. What's your partner think about birth control? Try and use judgmental language. That's a whole other topic in and of itself. And what you do want to do, again, is talking about confidentiality. And sometimes when I get into these direct questions, I go, just to remind you, this is private and confidential, and we're not going to disclose this to people who don't want to disclose this stuff to. Always go through limitations. Thank you. And sometimes you have to go into second-tier questions. So the way to developmentally talk about this is to think about, don't just go right into sex. When did they have a crush? What was their first crush like? But getting into some of these things more about above the waist. The safety of the relationship. How do they feel about this relationship? Are they attracted to guys, girls, both, and they don't know? These are more specific questions around age, and this gets into more higher risk behaviors, number of partners, what kind of sex you're having, birth control, etc. And the last few areas, the heads or shades, is sort of the depression. I think this is very important. But this is just showing you Nevada. There's a little bit higher on the depression and suicidality. These are some things to think about. One area that's really, really important, again, mentioning social media. That can be really, really damaging. There's a lot of evidence to show that social media can be really, really damaging. And for safety, we talk about, we think seat belts and all these other things, but I think this is an important one, relationship. I have a whole talk on adolescent relationship abuse. It's really a huge problem. And it's actually very much internet social media based, not just, together, but this coercion that's happening. And one thing to note is this is when you're asking some of these questions and you get positive responses, this is not confidential. And you need to talk about that up front, and you need to talk about what the response will be. And that's a whole other topic. Drinking and driving, but this is like still one of the #1 causes of death of adolescents and young adults, is drinking and driving. And you guys are doing pretty good. So, and I do this with all my patients. Are you in safe relationships? Do you feel safe? How do you feel safe? And then talking about how they might negotiate if they are drunk, getting home, and these other things. So the important thing about, and this is, like I said, Reader Digest version. I'm sorry I had to whip through these slides because there's a lot of information, and you have access to this as well. But one of the best things to do is to not just sit there and lecture. I think it's really important to ask a lot of questions to kind of get them to bring out the things that they know they need to do, and empowering them to make the decisions about what they want to do. Oh, you're concerned about your weight? What would you like to have different? What were some things that have worked for you in the past? Just getting them to tell you what they know they probably know need to do. And if they don't know, that's when you fill in the blanks. And it's so much more fun to engage with young people. And to really tell them that you're really happy that they're there to see them, even if you're kind of putting on your smile and they're like telling the whole world that's off. It's like, you know what? I'm glad you're here today. It sounds like you've got a lot of issues and so forth and so on. And I bet you're probably the best expert at that. No one's really talked to you about that. But also having people kind of their age kind of help engage them in the healthcare system, I can't emphasize enough. So with that said, here's some websites, and you have this. A section on adolescent health, American Pediatrics has a lot of just basic patient handouts and parent handouts. Physicians for Reproductive Health, as I mentioned, all these slides and videos and everything are available in free access. The Center for Health and Law, now they're very good at telling you about laws, and I can talk a little bit about explanation of benefits that's happening in California, what's trying to be pushed across the state. And the Adolescent Health Working Group has a bunch of toolkits, one on sexuality, one on consent and confidentiality. We're just coming out with a new one on LGBTQI, I remember all the acronyms that's coming out soon. One on being trauma informed, a bunch of things. It's really helpful because they have just little handouts you can send up in clinic right there when you access them. I'm going to take questions, and then this is for the CME at the end. Thank you so much. I think I just about made it in time, correct? Okay. Thank you so much. Questions? Yes.
You talked a lot about like the locus of epistemological privilege in like patient and provider interactions. So thinking about that and our developmentally able adolescents or early adults, there are a lot of instances where parents are like parentifying them, and I mean, what are the ethical implications of that? And
that's a great, you know, like we just had to interview a 20-year-old you're developmentally appropriate, and the adult is not. And I think it's really getting that developmental assessment. And sometimes you have some information about that, like you have a 21-year-old functioning at a 4th or 5th grade level. So that's, you know, pediatrician, I kind of know what that means. But there's also the preparation for when they become legal and, you know, getting the parents ready, because they need to know that they may not have to conserve and be the health, you know, whatever. I think just I always work with people on a concrete level, no matter what. I deal with kind of all spectrums of development. I may have people who really they're not able to really make decisions that they can define them, right? But, you know, when you ask, just a typical example is when you ask a question to a concrete person, giving them choices as opposed to openness. We're trained to talk openness. You know, for example, it's like instead of saying, do you want problems with your weight, what would you like to do with it? Instead of that, you go like, well, do you think cutting back on juice, cutting back on this? You know, giving them those 3 options so that they can make a choice to make that decision. But getting down to that level so that they at least have some power over stuff and making all these decisions. Understanding where they are developmentally and how much they understand what you're asking. So I often have to use a parent, but I have to teach them. Let them make a choice. Put out their clothes. Put clothes in. Just these little things so they can make little hurdles and feel like they're making decisions. Shots, another one. You know, I won't, you know, get refusal, whatever. It's like, okay, I'm not here to just give shots. It's not my role. I mean, there's public health, and it's hard to teach someone that. I understand that. I go, let's choose which one of these, or have to talk to your parents about which one of these you want. Giving them concrete is the way I sort of get around that. Oh, is there anybody on the phone that has a question too? Because we can take questions from our satellite. So yeah, and there's no policy about this. And I can tell you, resource-wise, no clinic can have opposite-gendered people for all kids. In my family planning clinic, we do have a policy for female providers. Someone else is doing the pelvic type exam. That's sort of a standard. It's a gestalt, and I gauge it. It's a judgment call. You know, do I feel comfortable with this kid? Or I will ask the kids, would they prefer a same-gender person? But I've had younger boys actually not want guys sometimes. So I let them kind of sometimes. But I've had some interesting situations, so I bring that up. It's a great question. There is no policy about that. Some people always want to have someone in the room, but I work with both male and female providers. I think it's important to have male and female providers, not just all female or all male, being all male or whatever. Giving that option. It gets even to, you know, I have more females in my own panel, but I have a lot of guys who request a female provider. So just having that option. Again, it's like ourselves. Who do we go? When we go to male or female providers, we choose that. So why can't we share that decision? I often get a lot of patients that come on that line. You know, I can tell when I have 13-year-old boys, they're looking at me like, oh, what happened to the team today? I'm like, you know what? Your mom just made this appointment. I had the first available. You know what? Would you prefer? Yeah, we'll have you solve it. I think it gets into that. There are people that have issues. There's some patients that are out there, and it's like, you know what? I'm going to knock on my door. Can you come and do an exam with me? I do it with my residents and students as well. I have them, you know, have someone in the room with them when they're doing it. Other questions? Great. Another on the call? Is there anybody?
Yes. Experience in the patient EHRs where we have the confidential parts. What your little tricks are about either choosing not to remember every little detail for those confidential questions. I think what Anne is doing for the point in time. So it's what you document.
Yeah. Yeah. Well, one thing that we did have a policy about visits after visits, we don't. It's decided no. There's too much stuff that's in there that you can't even, you know, protect. You know, from previous visits, cutting pages. It's really working with your system and seeing what's in the best. I was just saying earlier, sometimes it's even where your screen is in the exam room. Like you can have the chlamydia results posted in your camera. You know, thinking about little things that add that, you know, or pregnancy result came in and the parents were supposed to know I'm about to do a work, you know, that kind of stuff. I think working with your system so that you can figure out, we have a policy that if the parent ever wants information, it goes through our medical records and they delete out and deduct out anything that I can't get into the logistics of each EMR system. There's definitely better ones. The Society for Adolescent Health and Medicine has a whole working group working on this right now, coming up with like which EMR systems are friendly and confidential friendly versus others. They're not all user friendly for sure. I'm trying to do workarounds. Again, it gets to that you just sometimes have to do workarounds to get around it. And then you might, if it's not user friendly, just like I'm not going to put this information in. I can't guarantee it. You have to make a mental note or keep a separate chart. Great question. Anything else? Out of time?
It is 1:06.
Oh, sorry. Okay.